everyone. Our names are Elizabeth, Arun, and Anne, and we are current first-year students at Long Island University Post Genetic Counseling Master's Program. For this last module, we'll be walking you through a prenatal case for you to get a taste of what it's like to be a genetic counselor. So for our case study today, we have a patient named Jillian who came to our clinic because Jillian and her husband Bob are pregnant and they're worried about the chance that their baby may have sickle cell disease.
So, what are we going to do today? So, for our case, first we're going to do a family history and we'll go over an introduction to pedigrees. Next, we're going to discuss some testing options. So, what options do Bob and Jillian have? And then next, we're going to do a risk assessment and calculate the chances of the baby having sickle cell disease, and then end off with some ethical dilemmas that we might encounter in this case.
So let's get into family history. What is family history? So basically, the family history is a summary of health information for yourself and for your family members. Pedigree symbols are used to represent the gender and circumstances of these different family members, and all of this is used to record ages and medical conditions of family members. All of this is helpful to determine if a genetic condition is inherited and what the risk that future children and or other family members will develop this genetic condition. And so
when we're doing a family history, something we'd like to do is draw a pedigree. And a pedigree can be drawn by hand or it can be drawn using computer software nowadays. And some major components involving a pedigree include families that share genes, environments, and often their lifestyles. We also collect a family history, which is represented in this tree-like diagram or drawing called the pedigree. And when we draw a pedigree, we first start with the proband and move up the family tree. The proband is the person seeking genetic counseling, and in this case, the proband would be Jillian. So here are some of the more common pedigree symbols used. Feel free to screenshot this or write them down, as we will now be using it to draw out a pedigree for Jillian and Bob.
So we're going to walk through as if you were a genetic counselor. So your job as a genetic counselor is to take this family history information that we've provided with you and translate it into a pedigree. So we're going to walk you through the steps. So during the session, you find out information that Jillian and Bob shared with you. So Jillian shares with you that she is 28 years old. She has a younger brother who is 26 and a younger sister that is 24. She shares that her brother was diagnosed with sickle cell disease when he was 5 months old. Her sister was also found to be a carrier for sickle cell disease. Both her parents are alive and well with no severe medical issues. Her mom is 50 and her dad is 52. Bob is 30 years old. He has an older sister who is 33 who has no health issues. And both his parents are alive and well. His mom is 59 and his dad is 60. Feel free to screenshot this and refer back to it as you need to. So first step, how would we represent Jillian and Bob on a pedigree? We're going to give you 3 options per question. So choose what you think is the best answer between A, B, or C. And feel free to pause the video to think this through and then continue whenever you're ready. Great job. The correct answer is B. A is incorrect because Jillian is a female and therefore should be represented as a circle. C is incorrect because Bob is a male and therefore it should be represented as a square. So how would we represent their pregnancy on a pedigree? Again, feel free to pause the video to think this through and then continue when you're ready. You got it. The correct answer is A. B is incorrect because the diamond in this case would represent that Jillian and Bob's child has already been born and is gender non-conforming. C is incorrect because the circle would represent that Jillian and Bob's child has already been born and is a female. Now we're getting into some of the bigger questions. How would you represent Jillian's younger siblings? Again, pause the video to think it through and continue when you're ready. Good job. The correct answer is B. A is incorrect because Jillian's brother should be represented as a shaded square. This is because he is affected with sickle cell disease. C is incorrect because Jillian's sister should be represented as a circle with a dot in the middle because she's a carrier of sickle cell disease. Moving on to Jillian's parents, how would we represent them on the pedigree? Again, feel free to pause the video and continue when you're ready. Amazing job. This one was a bit tricky. A is incorrect because sickle cell is an autosomal recessive condition. This means that Jillian's parents have to be carriers in order for both Jillian's brother to be affected and Jillian's sister to be a carrier. B is incorrect because Jillian's father does not have sickle cell disease. In addition, both of Jillian's parents should be represented as carriers. Last question. How would you draw Bob's side of the family? Use all of the skills you've learned so far. And again, feel free to pause the video to think this through and continue when you're ready. Excellent job. The correct answer is A, our final pedigree. B is incorrect because Bob's older sibling is a female and there should be represented as a circle. C is incorrect because Bob's parents do not have any affected children and we do not know if they have had genetic testing before. Therefore, we can't assume that they would be carriers without more information. Therefore, Bob's father should be represented as an empty square and Bob's mother should be represented as an empty circle. So congratulations, you have completed the entire pedigree for Bob and Jillian's family. This is what the final pedigree looked like, and feel free to reference it back as we move forward into additional questions.
All right, now that we have conducted and went through the family history and created the pedigree, we are now going to go over some genetic testing options that Jillian and Bob can pursue. So there are a variety of tests available throughout before pregnancy, during pregnancy, and even after the baby is born. So, for example, we have carrier screening, and this is a genetic test that tells you if you carry a gene that can cause certain genetic conditions like sickle cell anemia. And this is usually done before pregnancy. Next, we have some procedures that we can do throughout the pregnancy. These are diagnostic procedures. The first one being what we call chorionic villus sampling. And this diagnostic procedure is done between 10 to 12 weeks of pregnancy, and it involves the sampling of the placenta for the identification, again, of chromosomal abnormalities or genetic conditions in the baby. Another test, diagnostic test that we can do during pregnancy is a little bit later, and this is done between 15 to 20 weeks of pregnancy and is what we call amniocentesis. And this involves the sampling of amniotic fluid for the identification, again, of the same things, chromosomal abnormalities and genetic conditions in the baby. And lastly, there's a test that we can do after the baby is born, and this is what we call newborn screening. And this is a genetic test that can tell you if your child has a genetic condition shortly after birth. So there are many tests, other tests that we can do as well. For example, throughout pregnancy, screening tests like trimester screenings, non-invasive prenatal screening test, and ultrasounds are used for everyone to screen babies at increased risks that would benefit them. Though they do not necessarily mean that the baby has a condition. Rather, we have diagnostic tests, like I mentioned before, amniocentesis and chorionic villus sampling, that would provide us a more accurate answer of those conditions. Though they do carry some small risks, such as miscarriage and infections, while the screening tests do not. For this case, let's imagine that the couple does not want to pursue CVS or amniocentesis because they fear those small risks. They also don't want to wait until the baby is born to find out through newborn screening. So the best option ideally would have been done before pregnancy, so Jillian has elected to pursue carrier screening.
All right, now let's talk a little bit about the chance of this baby having sickle cell disease based on the results of the carrier screening. So basically, after carrier screening, it was discovered that Jillian is a carrier for sickle cell disease. What are the chances now that their baby will have sickle cell disease? And something that we can use to be able to figure this out is something we call a Punnett Square. What is a Punnett Square? Basically, it's a square diagram that's used to predict the possible outcomes of a quote-unquote mating pair, such as Jillian and Bob, in regard to a trait like sickle cell disease. A Punnett Square is based on the concept that we each have two copies of our genes and we inherit one copy from each parent. As parents, we also give one copy of our genes to our children and our partners give the other half. A term you may have heard Elizabeth use earlier that is important to define now is called autosomal recessive, which is basically a condition where you need both inherited copies to have a change to have the condition. Parents, that means that the parents of a child that has an autosomal recessive condition, these parents often carry one change copy themselves, but they don't have the condition because they have a second working copy still. And these parents are called carriers, which Jillian is for an autosomal recessive condition called sickle cell disease. Specifically, sickle cell disease is caused by changes in both copies of the hemoglobin B gene. So let's denote the normal copy or allele as a capital B and the change copy as a little b. So let's make a Punnett square. If Jillian is a carrier and if Bob is too, what are the chances of them having a child with sickle cell disease? So we can create this Punnett square based on their genotype, their big B's and little b's. So basically, since Jillian is a carrier, she has one normal copy, and then she has a non-working copy, hence the little b. And so does Bob. And so when we set them up in this Punnett square, what are the chances that their baby would have sickle cell disease? Feel free to pause and think about this and then continue when you're ready for the answer. You're correct, it's 25%. And this is because of these four potential options, there's only a 1 in 4 chance that the baby would have both non-working copies and inherit each one from each parent. There's a 50% chance that the baby will be a carrier, which means they won't be affected by sickle cell disease, but again, they can also potentially pass it on to their children. And then finally, there's a 25% where it's two big B's, where their child will not have sickle cell disease at all, nor will they pass it on to their children. Now, what if Bob theoretically was not a carrier? Feel free to pause and then try to figure this one out on your own and then press play when you're ready to see the answer. 0%, good job. And this is because if Bob has two working copies of the hemoglobin B gene, that means that even if the baby inherited the little b copy from their mom, Jillian, they still have one of Bob's big B's to be able to offset that non-working gene. And so there's a 50% chance that these babies will be carriers, but they themselves will not be affected. And so what happened from here? So basically, since Jillian was found to be a carrier, Bob also underwent carrier screening himself and was found to not be a carrier for sickle cell disease. Therefore, like we saw in that previous slide, their child will not have this condition, which is super exciting to hear.
All right. So this case had a happy ending, thankfully. However, this unfortunately isn't always the case. Sometimes cases are much more complex than this, and as a result, we want to close off this presentation with some food for thought that we hope you think about more when it comes to genetics. So some ethical dilemmas. One ethical dilemma is termination. So let's say we have another couple that comes in and discovers their child has sickle cell disease and wants to end the pregnancy. On one side of the argument, women should have the right to make decisions about their own babies. On the other side, some disability activists argue that it's ableist and even eugenic to terminate a pregnancy solely based on the presence of a disability. As genetic counselors, our role is to guide our patients to make the best decisions for themselves at that time through the tools, information, knowledge, and support required to make those decisions. Another related conversation is the rise of assisted reproductive technologies, or ARTs. Related to the former conversation, let's say we have another couple. Both are found to be carriers of sickle cell disease and they want to prevent or not have a child with this condition. Again, related to the former conversation, not only are these arguments between the right to decide versus it potentially being eugenic, but people are also dabble in the conversation of, is it natural for people to be able to do this? A third dilemma I want to discuss related to ARTs is technological advances like CRISPR. CRISPR is a gene editing tool that can be used to make genetically edited babies. This is known as designer babies, who have selected traits, lower disease risks, and even the ability to select gender. This begs the question, how far is too far? And with all these technologies being expensive, will they end up being exclusive for the rich? Will having a disability become prevalent only in poor communities? Finally, with genetic health comes the conversation of privacy and confidentiality. Let's say we have a couple that finds out both of them are carriers for sickle cell disease and wants to prevent anyone from knowing this information. So, of course, there are laws like HIPAA and GINA, the Genetic Information Non-Discrimination Act, that ensure that our information is private and only shared to authorized people like our medical team. However, what about when one of the couple's siblings is looking to have children of their own and their decisions could be impacted by the knowledge of their carrier status or this carrier status? What if this information could make them eligible for clinical trials for treatments and cures for this condition? How do we unblur these lines? So these are some of the many, many dilemmas and issues genetic counselors are still debating to this day. And at the end of the day, our role, again, as genetic counselors, is to be there to guide and provide information and the tools necessary for our patients and clients to be able to make the best decisions for themselves in that moment and at that time. So, on that note, we've hoped to have intrigued you enough to join us in more conversations in regards to genetic counseling.
We hope you've enjoyed this final module. We thank our program director, Monica Zach, and our professor, Heather Butts, for providing us this opportunity and guidance to create this module for you. Our slide template is also from SlidesGo, and for any questions or concerns, please do not hesitate to contact our program. This does mark the end of our module, and we're very grateful that you've been able to join us in this journey. Thank you so much.